when we start to talk about patient engagement, that it could not be more true than it is today. And when we talk about wellness programs and cost sharing, and part of the heavy lift that we have before us is making those changes. And making those changes in a Medicaid program that's been very traditional. And I congratulate Secretary Hazel for the work that they've done in the recent approval of the duals, because that's the kind of movement forward that it's going to take. And Lynn's right. We cannot do that from Washington, D.C. That's got to be done with states and private sector partnerships. What we do have a responsibility to do is provide what Lynn talked about with data. And we've tried, and yes, the hospital charges, I even had to shy away from that one, knowing my past history, but we released further charges this week in outpatient work. But equally important, and what I find very interesting, is the material that we released that's now available on the website about geographic variation, which is part of the point that Lynn was making about where Virginia stands in relationship to the rest of the country, because this really is about best practices and looking at the nation as a whole. The third thing I would say is he made the comments about Mississippi, so I won't have to, but Mississippi is an example of why we have to look at this. Innovation to me means three things. The Affordable Care Act to me means three things. What we're trying to do in CMS, three things. One is access. Because part of the problems that we have, and if you look at the map of the country that Lynn showed, if you look at New England, I am very sensitive to not always wanting to award grants or programs in New England, but he's right. It is because of their expansion of coverage. It is because of their release of data that it actually gives them a running head start for some of the work that's going on. So the more data we release that states and communities can take and massage and connect with their private data, the better off we're going to be. So the first point I will make, and I'll come back to that, is access. Part of innovation is about access. There is a hidden cost or tax to every employer, and I wore different hats during my 25 years at HCA, but the hat I hated the most was every year when I had to switch from a provider to the employer who was trying to select health insurance and trying to figure out how to move employees to get the best value. And knowing all along that the number of uninsured or people who are underinsured in this country is a cost that everyone bears. Lynn's also right, Medicare doesn't bear that cost. If you look at the Stephen Brill article, which is probably the longest article I've read in 10 years, if you look at that article, I walked away with three things. The hospital charge system is complicated and probably not based in reality anymore. The second thing is insurers didn't look so great. And the third one is Medicare looked like a deal. Now, we all know that Medicare is not necessarily a deal, and there's still plenty of room in payment reform, and that's one of the things that the Affordable Care Act allowed us to do. The next thing I will say is on the Medicare trustees report, the point that Lynn wanted to make, we were at the Medicare trustees annual meeting last week, and we had the great news of saying that we were expanding the fund for 2 years. But I think the reality is we know how many seniors are coming into the program, and I'm going to soon be one of those. Currently, there's an influx of about 300,000 individuals a month. That's a huge number. There are about 240,000 who exit the program each month, most of that through death, unfortunately. But if you look at that, that is something, no matter how great we're doing on the per capita, we have an influx of just individuals that we're going to have to deal with. And if you look at the Medicare trustees report, which is really, really some heavy work, it talks about what the country will look like in 75 years. I have trouble figuring out 5 years, but part of their responsibility is to figure out 75 years. And they put in alternative scenarios over the very issue that Lynn talked about is, would Congress or would the country have the courage to continue some of the payment reductions and other things that are talked about? So there's an alternative scenario in the Medicare trustee report, which basically says we don't trust Congress to stay the course on some of these payment changes. The other piece that I would also mention is if you look at Part A and Part B in Medicare, you will see that Part B will soon surpass Part A, and that is outpatient physician payment and anything post-hospital. And that's an important point because it is there that we're seeing double-digit increases in pricing and in volume. It's also where, if you compare the United States to the rest of the world, we have the greatest variation. So there's a lot of work to be done. It cannot be done by CMS alone. I'm proud of what we've done in CMS in the last 3 years because I think we've kind of changed the messaging, if you will. We've gone from being kind of what I'll call the big, and we're still big and we're still bureaucratic and we're still slow, so I don't want to pretend that we're not. But we've tried to do a better job of reaching out to the private sector, having quality measures match, having data match, and working with insurers. And while some of the things that I may say in my talk may sound not so friendly to insurers, let me assure you that we would not have the partnerships we have today without hospitals, without issuers, and that's particularly true as we move forward on the exchanges in the marketplace. The last piece that I would bring up that Lynn mentioned lightly, but I want to emphasize, is where we're going with health IT. Despite some of the negative that's been out there recently about health IT and what it does and doesn't do, what I'm most concerned about and what will be required for us as we go through 2013 and into 2014 is our ability to have interoperability. So when we talk about sharing data, we're also going to have the ability to transfer data across providers, which creates another hole. And that's scary stuff too, but it's going to be really, really required. So when I think about the Affordable Care Act, I think about three things. I think about cost, and there's a lot in the Affordable Care Act that deals with cost. Is it perfect? No. Does it need further work and modification? Certainly. The second area is access, and for better or worse, we believe that until everyone has some form of insurance or coverage, there's going to be hidden costs that we can't control. And third is the issue of quality. And despite having really, really strong health systems and really, really strong economy in many ways, if you look at our outcome data and compare it to the world, we still are struggling. So those are the 3 points, they're the 3 pillars, and we think they all have to work together. So I would argue that what the Affordable Care Act has done is it's brought attention to a long-term problem that we've all talked about for years, and we've all said we've got to fix this, it's not sustainable. And I would also argue that while the Affordable Care Act may not be perfect, it's an attempt to move forward in some very complicated environment. And I won't go through any of the discussion about the economy and this sort of thing, but what I will say is over the last 3 years, we have seen the lowest healthcare cost growth that we've seen in a long, long time. And for the first 2 years, neither the Secretary nor I were willing to talk about it because it was so difficult to separate what was due to the recession versus what was actual changes that were underway due to the Affordable Care Act or just due to business in general. But by the end of this year, and if you look at the job growth and the other things where the country is stabilizing somewhat, we have decided that maybe it's a mixture. And so we are starting to talk about how we can continue that. And when I talk to large employers, I was in Georgia a couple weeks ago talking to a group of large employers, and I was in Miami that same week talking to the Chamber of Commerce. And what I'm hearing from large employers is that they are seeing better results. They're seeing the 4 to 5% range, which is what we're seeing. And so what I'm asking for each of you today, as a private employer, you can help with this, and we're going to need your help with this. So you need to be comparing your cost growth to Medicare, to Medicaid, and seeing if we can all align incentives. So let me talk a little bit. I want to switch now to a little bit about what's ahead for employers and healthcare over the next few months. And I can probably say what I think the world is and what I think the world isn't, because I think there's been a lot of misconception. Frankly, we've been guilty of just not providing a lot of information. So you'll see in June, July, August, and September a more outward effort on our part nationwide to try to talk about what you can expect in the fall as it relates to the exchanges of the marketplace. So I'm going to approach it from the employer side, and then I want to approach it from an individual side. From the employer side, if you're a large employer, I made the mistake when I was in Atlanta of saying, well, this doesn't affect large employers. And then, after I got my head back on, I started to say, okay, then you tell me as the large employer how it affects you, okay? So we actually had a good conversation. So this is what I heard, and so I want to talk about what I believe to be the facts, and I think the large employers there had very good facts. The first is, for many large employers, or at least in Georgia, they were going to be impacted by what we call the Cadillac tax, which takes effect a few years down the road. And so I said, well, you know, the Cadillac tax was designed for a reason. It was designed to create some incentive for employers not to offer such rich benefit packages, if you were, to try to have essential health benefits covered. And so that is an avoidable tax. And then they all admitted that they're working on getting to that point. They don't intend on paying the Cadillac tax, so they intend to get their benefits into what I would call more in line with what we see as a general private sector or Medicare or Medicaid benefit. So that was the first one. They said that they saw their cost growth in the 4 to 5% range as a large employer. I said that is what I would expect. That's what we're seeing, and we talked about where that was, chiefly outpatient, some pharmaceuticals, et cetera. Then they talked about what they see as the device tax and the other issuer taxes, which are true taxes, right? Because they are required to help cover some of the expansion. So we actually had a good conversation, and I left there feeling like large employers, at least the group I was talking with, had done their homework. They understood what the future looked like for them. I didn't see anyone rushing to get rid of employer-based insurance, which is what we hear all the time in the press. I'm sure people evaluate that. Every business evaluates what they're going to do or not do as they go forward. I did hear some concerns about the 28-hour, 30-hour issue of part-time versus full-time. And these are the kind of messages I take back to my boss and I take back to the Hill. So that was the large employer side. When we get to the small employer, it's an entirely different world, because there are a lot of changes for the small employer, and they're designed to help the small employer. So let me talk a little bit about that. First of all, let me talk about what is required and what isn't required. If you are a small employer who has less than 50 full-time equivalent employees, you are not required to have health insurance. We certainly hope you will, and that's part of the work of the exchanges, but it's not a requirement. And I think that's confusing for a lot of people. And as we all know, small business, and many of them less than 50 employers, is a big part of our growth and a big part of the general, if you will, way we do business in this country. If you are 50 employees or above, there is a requirement. You can elect not to cover, but if you don't cover, then there are penalties paid if your employees actually access the exchange. So for the small employer, the work that's been done around the exchanges is designed to create a more competitive marketplace. It's also designed for those employers with less than 50 to give some very frank incentives. For instance, if you are an employer who has less than 50 employees and you decide that you want to provide health insurance and you're working with low and mid-wage employees, which is frequently the case, you would be eligible to up to a 50% tax credit for any premiums paid. And that is designed to try to obviously get small employers to have insurance, but again, not a requirement unless you're above 50. For those in the 50 on up, before you actually become a large employer or enter the self-insured market, the idea behind the exchanges is to get the data out there in a public way and let you shop in a public way with a standard form. And although we describe the exchanges in a very complicated way, this is really how it works. You take a state, issuers come in and they bid on the state. We go through those bids to make sure that we feel they are fair and competitive. We feel like they cover every county and city in the state. And obviously we want more than one issuer to promote competition. Now, promoting competition is not a one-day event. If it was, someone would have already figured this out and we wouldn't have this problem. It will take us years to really create robust competition in some markets. Mississippi is an example. North Dakota is an example. Alaska. These are markets that do not have 30 or 40 issuers today. And just because we created the Affordable Care Act doesn't mean they'll have 30 or 40 issuers tomorrow. This will take some time. But what it does do is it allows an employer and an employee or an individual to go online and actually look at what plans are available to them and how much they cost. And there is a piece which applies to all employers, so large employers hopefully start to benefit from some of this too, that's called standard terms and conditions, which means that you no longer, when you're comparing plans, which you could always do as a large employer, and I've been fortunate enough to work for a large employer, I could look at the plans and try to figure out deductibles, maternity care, what it cost if you had to have a mammogram, et cetera. But each insurance company had their own way of saying what that meant. And so it was confusing to folks. So part of the Affordable Care Act puts that in standard language, standard format. Part of the Affordable Care Act says you have to cover 10 basic conditions. Now, again, if you're a large employer and you're already covering it, it really is not designed for you. You continue on. It's designed for those small employers who sometimes did their very best to cover, but they found out the hard way that maybe their policy had a really high deductible or didn't cover a lot of benefits, and so now there's a certain standard of benefits. So enough on that. I will have to put in one last plug, which is some of the things that have happened is this has eliminated pre-existing conditions. This has expanded coverage up to age 26. This has eliminated lifetime caps. So these stories, these horrible stories that you read about case to case, or you have a friend who experiences it, it's designed to make those go away over time. And it's designed to transition over time because we understand that both employers, individuals, and insurance companies cannot make these changes overnight. So what happens over the summer and fall? Well, we've said effective October 1, individuals can sign up for coverage that would go into effect January 1. And that will be true. So what you will see is we obviously have a combination of state-based exchanges and federal exchanges. And obviously Virginia is in a hybrid. So what will happen for a state-based exchange, so let's pick a California or a New York, they will handle this entirely. Now they will use what's called the federal hub to pull data down, to work with the data. There's only one federal hub and it supplies the entire country. So they'll pull data down, they'll be able to look and select and sign up for coverage. In a federal-based exchange, we will be doing that, and we'll do that through a couple of ways, and we will need your help. One is what's called the Navigator Program, which is currently there are grants out today for federal states to actually, if you will, have partners inside the state who will sign up individuals, work with individuals, help them explain insurance, help them sign up. That's the Navigator Program. We'll also have a cadre, if you will, of in-person assisters where we'll actually have individuals hired and trained to help people. Folks can sign up online. They can sign up manually. We'll have a 1-800 call number. So there are various ways you can access this, but buying insurance is complicated. So we feel like we're also going to need individuals who are trained who can actually offer in-person assistance. We will also have that available inside states. For instance, hospitals, it makes good sense. If hospitals want to be certified, they can be certified. They frequently do Medicaid applications today. We'll expand that to exchanges if they're interested. It would be voluntary. Same thing would be true for social services departments, health departments, libraries. We're working with the National Library Association now because they have computers, they have access, and they have folks who can be trained.